Today's module is on shoulder impingement syndrome. This has also been called rotator cuff tendinitis or shoulder bursitis. It should be distinguished from rotator cuff tear, which is more serious and involves an entire disruption of the rotator cuff, and that often requires surgical referral, at least for a complete rotator cuff tear. Patients often find this terribly painful. They can't lie on their shoulder at night, they can't reach with their arm. And early diagnosis is helpful for patients, both that they can feel validated, that their diagnosis is understood, but also that you can initiate treatment. Treatment, as always, will start with simple things. I like to say low tech is better than high tech, and no tech is better than low tech. So we try physical therapy, chiropractic, massage, anti-inflammatories. If they're not improving, they often see someone like myself for specialized injections, and ultimately they might need, in some cases, surgical consultation. We'll talk more about treatment in the history and physical exam portion of this module. And when we talk about shoulder impingement, we're really talking about impingement of the subacromial space. Let's put that in English. Here's the acromion, shoulder blade. Sub means under the shoulder blade. And this is actually a space with a bursa. The body makes bursas in order to solve the problem of too much friction between two surfaces moving a lot against each other. And since the shoulder is very mobile, someone designed a bursa in here to kind of keep things fluid and going. It's a fluid-filled sac, but it can get an itis, it can get an inflammation, or a tendinitis, because on this side I'll show that there are a lot of tendons going through that subacromial space. And the specific tendons are two of the most famous rotator cuff muscles, supraspinatus and infraspinatus. One is above the spine of the scapula, super to the spine, the other is infra to the spine. And so sometimes we confuse whether it's a bursitis, in other words, the fluid-filled sac is inflamed, or whether it's a tendinitis, which is an inflammation of the tendon of those muscles. Treatment's fairly similar. History is fairly similar. Patients will talk about not being able to lie on that shoulder at night, often getting pain when they try to reach overhead. Sometimes there's weakness, but usually not profound weakness. If there's profound weakness, we think of a competing diagnosis, rotator cuff tear. We always do a complete exam. So you have the patient go into flexion, patient go into extension, Sperling sign, which we use for radiculopathy. And these are all important because, in fact, you can have shoulder pain here when you have a pinched nerve in the neck, for example, a C5 radiculopathy. So it's important, again, to be complete and start at the neck or the spine and move outwards. When you do the shoulder exam, typically we bring the arm up, and patients will often get pain here. And one thing to emphasize, almost all shoulder exams or all shoulder injuries cause pain out here or at the top of the shoulder. Sometimes patients come in and say, my shoulder hurts, and they're pointing here. That's the neck until proven otherwise. Really, shoulder pain is out here. So when you bring the arm up, they might get pain here. It might be restricted compared to the unaffected side. Hawkins test, which applies extra compression into the subacromial space, is classically painful with pain out here in the lateral humeral area. Sometimes we do something called NEER test, N-E-E-R, and that will cause similar pain as Hawkins test, and it depends on where the compression site is in the subacromial space. Okay, so we're going to move now to our neurologic exam for the shoulder, but again, we're going to do a complete neurologic exam. There are a few muscles that I add for the shoulder, though. One is serratus anterior. Hold your arm up, and hold your arm up here. Now, if you were in medical school or in your training, you might have heard that for serratus anterior, there should be winging of the scapula when you push against the wall. That's a very, very profound injury to serratus anterior, so-called long thoracic palsy. Most patients in common practice, they just have a subtle weakness. So when we bring the arm up and they're weak with serratus, they can't quite maintain that. And what serratus is trying to do is abduct, or bring the shoulder away from the body. And those patients who have impingement, for one reason or another, they can't quite hold that, probably because it's causing some pain. The other thing we're going to test for is one of the classic rotator cuff muscles, infraspinatus. So we have them push the arm outward, keeping your elbows at your side, push outward, and the affected side, let's say the right side here, will be weak, but typically painful and weak, and typically not profoundly weak. If profoundly weak, you're thinking more of a rotator cuff tear, C5 radiculopathy, all the way to very unusual diseases. I've even picked up Lou Gehrig's disease when someone sent them in for, quote, rotator cuff tendonitis. So again, a good neurologic exam is important. The rest of the exam will be pretty normal generally. That was shoulder abduction, biceps, elbow flexion, triceps, etc., elbow extension, and I've shown that in other modules. So the key here really is the impingement signs, Hawkins test, if not near test, some restriction in range of motion, and the pain with activating the rotator cuff muscles. Sometimes providers can palpate just in the bursa area here, and that will be tender as well. There are some other similar diagnoses. Sort of the AC joint can get arthritic. I'll show the AC joint here, and that by itself can also add to the impingement. So here's the AC joint, acromioclavicular joint, and that might get spurring, and that causes some of the impingement for some patients. Treatment, it's often postural, often strengthening some of these scapular stabilizer muscles, trying to get the shoulder, bring the patient to bring their shoulder back, often done with physical therapy, sometimes chiropractic, re-educating the patient about how to stay out of those impinging positions. Occasionally injections are done. We used to do steroid injections in my clinic. Now I generally use platelet-rich plasma, or PRP, because steroid injections generally don't last. In cases that really are severe and do not respond to conservative care, surgery is an option. What it would involve is, I'm going to go back to the model here, they actually tend to resect or bring away some of this joint here and open up this subacromial space. They call it subacromial decompression, often do it with arthroscopy. I'd say surgery is rare though. Probably 1 out of 15 of my patients need surgery for this condition.